I think that we'll go ahead and get started. We have lots of people who have joined and are waiting for the great show that we're going to offer you today. So welcome everyone. I'm Mary Ann Faison. I'm the president and CEO of the Texas Business Group on Health. And we're delighted that you're joining us for part two, webinar two of our field guide, claims data field guide series that we started last January was the first one, January 22nd. Today is part two on pharmacy claims and PBM transparency. And then just a quick reminder, on March 26th will be part three, which will be integrating data for strategy and oversight, which will be the third part of the field guide. And just to kind of talk about the Texas Business Group on Health to start with, we actually have two arms of the Texas Business Group on Health. It's a statewide coalition composed of three major coalitions in San Antonio and in Houston and in Dallas-Fort Worth, and we're working on Austin. So if anyone is here from the Austin area, you'll be hearing more from us about participating in the TBGH. And then we have companies from all across the state and many other cities across the state who are welcome and participants in this as well. We also are part of the National Alliance of Healthcare Purchaser Organizations, which is kind of the umbrella organization of coalitions. There are about 40 like us around the country. And we participate in that and have many, many resources that we have access to through the National Alliance. As far as this program goes, can we go to the next slide? Oh, I'm sorry. I should mention about membership. If you want to join as an employer from other parts of the state that aren't in the coalition areas, we would like for you to join as part of the TBGH today for $500 for the year and have access to all the resources. Then on to the next slide. This, as I said, each coalition, San Antonio, Houston, and DFW have different programs coming up. The Dallas-Fort Worth Business Group on Health has an upcoming event. We have a series called the Rethinking Oncology Care. It's called the Triple Crown Cancer Care Series that will go throughout this year, focusing on affordability, accessibility, and quality exceptional care. There'll be a series of webinars along with this, as well as in-person meetings and a symposium in the fall. First kickoff meeting is March 10th. It's in person, and you all are welcome to come as participants in TBGH to any of these meetings. Next slide. The upcoming webinar that I mentioned is going to be on March 26th, so please mark your calendars for that. And then the next slide we have here is this. I'm going to let Chris talk about this, but I want to thank Chris, first of all, for putting together this webinar series with Chris Deacon. And he'll introduce Chris, who led the first series in January. Chris, this is an outstanding program with the field guide that we have developed for employers across the state of Texas, members of Texas Business Group on Health. So I thank you for introducing it and kind of carrying it through. And we're delighted to have this as a tremendous resource for the TBGH members.
So thank you, Mary Ann. And let me just talk a little bit about Texas Employers for Affordable Health Care, the elevator pitch here. We are a C4 organization, and we work with the state legislator to get employer friendly legislation passed so that employers can continue to provide valuable benefits to their employees. We've had a couple of really good wins over the last few sessions. One was House Bill 711 a few sessions ago, which prohibits anti-competitive language in contracts between hospitals and health plans. Another one from the last session, Senate Bill 926, which allows for plans to incentivize navigation to high-value providers with no deductibles, co-insurance, et cetera. We actually met last week with the Texas Association of Health Plans to talk about how this legislation impacts ERISA preemptive employers, which most of our members are. So we'll be having some more educational webinars on how these bills can be used to enhance your strategy for your health plan. But Texas employers, it is an employer-only um, membership. We are actually looking at perhaps allowing affiliate members, but we really need to think about that because we do not want to create any perceived bias with legislators by having vendors in the healthcare space. So that is why it currently is just limited to employers. We currently have 65 employer members, but we recently had signed an MOU with the Texas Business Group on health. So by inference, employers who have not individually signed up with Texas employers are members of Texas Employers for Affordable Health Care. This is all confidential. No information of company name is provided, but we do aggregate this information to say that we have X number of employers in these industries who want the legislators to not forget that they're part of the equation. So if you are a member of Dallas, Houston, or San Antonio, you are automatically a member. However, to obtain the field guide, you still must go on and um, request it. And there's a QR code here if you want to take a quick snapshot of it. And we'll provide this in the slides afterwards, or you can go to our website that you see there and register and then download the guide. We've received so many wonderful comments about it. Why data is important, perhaps most important, how to get it, and then how to use it. So this session is how to use it from the PBM side. So that's just a little bit of information. Let me say that if you have any questions throughout, please enter them in the chat. We'll make sure that any question that is asked will be answered. And so with that, I am really pleased to introduce Chris Deacon. I've known Chris now for 6-7 years, started running into her at National Alliance events. Marianne mentioned that. She is without question one of the top advocates for employers to access and use their data. She has learned a lot of wonderful things through it. She'll probably mention a thing or two here, but I will just ask Chris to introduce herself, and you will be pleased with what she has to say and how she says it. So with that, Chris, the stage is yours, and I'm going to get off mic and off picture.
Great. And first, let me just apologize for my voice. Please know it is much better than it was yesterday. So it was a little nerve-wracking knowing that this was coming up. Hopefully some of you are on the first webinar. I'm not going to go through my resume or credentials. You can look them up. I'm just excited to be here and take the next 49 minutes to walk you through what I think is so timely and important given all of the emphasis and focus on the PBM space. If I'm sure you've heard, if not, the new sort of the CAA of 2026 and the Department of Labor's new PBM rules really raise the baseline expectation when it comes to pharmacy and PBM. The issues no longer are we getting good rebates or what was our trend. It's really how fiduciaries can assess how PBMs are paid, what counts as compensation, and whether that compensation is reasonable. Now, I'm not going to read the statutes, but what I want, what I think the new requirements matter because they really narrow the gap between what a fiduciary is responsible for and what a fiduciary can realistically see now. The gap used to be, pretty big. And so it was defensible that we sort of didn't know what was going on. but given these new rules and regulations, it is getting much smaller. So as we go through the presentation and the slides, I'd encourage you to think about or think less about sort of compliance box checking and more about how you are going to take this data from a governance perspective. So if compensation has to be disclosed, how are you going to evaluate reasonableness? If, revenue has to be described, how are you going to trace it? So that's sort of the frame for today. And I'm really excited to get to my last slides, which are some examples that we can walk through that I think really demonstrate the value and utility in having your pharmacy data. So again, these are some of the recent changes. The CAA 2026, 408B2 specifically within that section really expands who needs to disclose direct and indirect compensation from an employer perspective. So it's no longer just consultants and brokers. It is PBMs. It is TPAs. It is covered service providers to the, sort of they cast the widest net they could in the language. And also then the DOL proposed rules on more pharmacy data and reporting for employers. I would encourage you to write in or maybe through the coalition supporting those rules and supporting that those rules really go further and not just focus in the PBM space, but really broaden data disclosure to the TPA space as well. Okay, next slide, please. Yeah, again, I'm not going to, this isn't about the CAA. However, it is really important because we are talking about data, and a lot of this is about data and information that is going to be made available. Detailed reporting mandates, expanded audit authority, right? Again, compensation disclosure, and for the CAA, the implementation timeline is 30 months after enactment. However, most of our PBM contracts are going to be, well, not most, but some are going to span the lifetime of that 30 months. So what you need to think about today is, what does my contract look like? What does my RFP process look like so that in 30 months, I'm not having to do, drastic amendments. I'm setting myself up to be compliant today, right? For what changes are ahead. Next slide. Yeah, and I already talked about this, the proposed rule. This is going to be effective, immediately. And those disclosures are going to have to be made, at the time or before contracting. So you want to pay attention to that language. I put these on the slide only so you'd have access to them after. And Chris, I gave you these documents. It walks through the new DOL rule and the CAA, where they overlap, where they complement each other, where they have different audit rights or scopes. It is a lot, it's dense, and to try and read the statute and the proposed regs together is difficult. So I've tried to synthesize all that information into some usable documents, and those will be made available through Chris after this to the employers. Next slide.
Just let me comment on that, Chris, just briefly, and because we've got a wide audience here today. This will be made available to all of our employer members and will be a resource. It will be included in our section on our website with employer resources. So you will need to be a member of Texas Employers, and you'll be able to have access to all of this information.
Thanks, Chris. Next slide. Okay. So I think that, one of the most important things here is really getting your handle on some of the terminology and verbiage that when we talk about pharmacy and what it means, and some of the essential things to actually understanding the economics of a PBM or a pharmacy transaction. So, identifying the drug with, an NDC number. And that means not just what is this drug, but what is the quantity? What are the days supplied? What's the fill date? Because timing matters here. And then you have what does the drug actually cost, right? And that's the ingredient cost calculation. And then we have a bunch of acronyms that are, you have to keep straight in your head, the MAC, the WAC, all of it. And then, understanding the pharmacy pricing. So not PBM pricing, not drug pricing, but actually the pharmacy, what is the pharmacy getting paid? And then really important, again, benchmark pricing. So now that you're going to have access to all this information, how are you going to know what's reasonable, right? You can't do that in a bubble. You're going to have to figure out how to benchmark and make sure that you're paying reasonable with prices and compensation to your PBM and vendors. Next slide. So this is just talking about some of the ways that you can benchmark with that data. So some of the things that you want to benchmark yourself against, brand effective rate. So, a generic effective rate. What is your discount performance? Do you have any inflation guard provisions so that, throughout the year, prices aren't getting jacked up and you're surprised, when it comes time for renewal? And, MAC list integrity and price protection guarantees. I go into a little bit more detail underneath those bullets as to what you can do in that space. But now that you have some access to this information, those are things you can and should do to protect your plan. Next slide. So, spread pricing. Spread pricing was not disallowed under the CAA or the DOL proposed rules. And just to sort of level set, spread pricing is calculated as what the plan is charged less what the pharmacy reimbursement is, right? So if the plan is charged $20 for a drug and the pharmacy that provides that drug is paid $15 for that claim, the spread is going to be 5. Now, there's a lot of, it sounds simple when I give an explanation like that, but there's a lot of things that actually can impact that spread. And one of the reasons, like I said, about payment dates, timing is really important here. So in your data, pay attention to the timing of payments, et cetera. Post-adjudication adjustments. So perhaps the plan is charged $20 for that drug. The pharmacy is given $20 for that drug. But later, at some later date, that money is clawed back by the PBM. And so while it appears sort of on par in the beginning, there are post-adjudication things that can happen that can result in spread pricing. And also in this vein, especially when it comes to spread pricing, you're going to really want to know and have some sort of idea where the affiliate pharmacy, indicators are. So, does my PBM also own the mail order pharmacy that I'm, steering members to, and the specialty pharmacy that I'm requiring them to use, right? And the chain of retail pharmacies that I'm steering them to? Where in that vertical integration chain, as you look at the information, understanding who's integrated with who is really important, because what you see is often that the enterprise value of a transaction looks very different from sort of a single value of a transaction. So what did that pharmacy receive, right? But if that pharmacy is part of an enterprise, understanding the enterprise economic impact with all of the, all up and down the chain is really important. Next slide. Yeah, so again, these are just a few more notes on the some of the upcoming information that's going to be available to you on NDC level rebate attribution. So, today we have sort of broad rebate guarantees. We guarantee that, you're going to get up to, or you're going to receive at least $10 million in rebates. And what you'll see is those, as you perform, those payments are made, some quarterly, some annually, some biannually. But they're aggregated, right? You don't know which drug got which rebate in what amount. But you will, you should, and you will know that in the future, which is exciting. But with great knowledge comes great responsibility. So being able to understand that and monitor it is going to be really important. Next slide. I just wanted to list sort of, and you probably are very familiar with this, but all of the different ways in the pharmacy transaction, where the compensation, I'll call it the compensation waterfall. But these are all the ways that, in a claim, monies can be made by your vendors. And again, I'm not pointing this out to say there's anything wrong with it, to say that it's good, bad, or ugly. What I'm saying is you need to understand not only what is part of these transactions and what makes up this revenue source for them, because you're paying for it. And again, going back to my first point, this isn't I collected a report, because the law told me to, or I got this reporting. It's now enabling you to put some guardrails and governance structure around assessing the reasonableness of what you're paying for with the dollars that you've been entrusted to or with by your employees and your employer. Next slide. Again, this is going back to my point about understanding affiliates and affiliate risk. So again, pharmacy ownership classification is really important. What are you paying attention to? Are there different reimbursement formulas? Is there steering going on to affiliated formulas? And if so, is that steering resulting in savings, or is it resulting in a higher cost transaction? Looking at specialty exclusivity arrangements, are those affiliates? Again, are you winning in that transaction or not? So ownership structure is really important. Next slide. So in order, and this is a space that's only going to get more important as drugs become more and more expensive. Some of the fields that you're going to want to familiarize yourself with is diagnosis association. So knowing that the drug costs $15,000 is one thing. Knowing what that drug is intended to treat, right? Like what are the diagnosis associations with that drug are going to be really important, especially as we get to a place where we can start to bring together our pharmacy data and our medical claims data. Understanding prior authorization criteria, step therapy logic, is there a logic here? Refill timing adherence, really important. Are we one of the, this is just anecdote, one of the areas that we ended up looking at in New Jersey, only because it was, I think, brought to our attention by somebody that wasn't responsible for the pharmacy spend, but was had access to that information for a quote, um, we had no guardrails on refills for lost medication. So let's say you go on vacation, you forget your drug that you had just filled your prescription for at the hotel. That drug costs $500 a month to the plan. Might only cost you 10 or 20, but to the plan it costs a lot more. And you left that drug somewhere, you lost it, right? So the plan is going to allow you to replace it. We're going to pay for it again. Okay, maybe that's okay once, but we had lost medications a lot, and many repeat offenders. And by turning off the ability to simply request a refill upon a lost, report, we saved north of $10 million. Now, we were a very large plan, so $10 million probably wasn't all that much, but these little dollars and cents matter. And it matters again from a governance perspective. And refill timing adherence is just one of those things that, like I just said, that you're going to want to pay attention to. It shouldn't be, at 14 days if it's a 30-day supply. Next slide, please. Okay. So again, what I wanted to provide you is, as a takeaway too, because you'll have access to this slide, just a little bit more information about what these files are and how important they are, and what you'll be looking at and why they're important, like I said. So, historical MAC file list, if you want to look at changes over time in those prices, you're going to need access to that. Remittance details. This is going to provide you with clarity on, the payment allocation and adjustments. And again, really important when we're talking about vertical integration and affiliated entities here. And then rebate invoice level files, so that we can make sure that the rebates that we've contracted for, the rebate guarantees, or if it's 100% pass through, it'll enable verification of those rebate calculations and the agreements that we've made around those. Next slide, please. Sorry. Audit and contract alignment. Now, again, some of the audit requirements and provisions regarding audits in this new law aren't effective again for 30 months. That being said, your contract cycle might span that 30 months, or you might be in an RFP where it certainly will span those 30 months. So you're going to want to really pay attention to your audit provisions and make sure that there is contract alignment with what you are supposed to be auditing, what are you able to audit, and the full scope of that audit. And even if you don't do that audit on a yearly basis, you must preserve your right in the contract to do so, not only so you can do it, but so that contract is, in line with federal law, and not, sort of per se unreasonable, as an ERISA plan. Next slide. Okay, so I wanted to spend a good deal of time on these examples, but before we dive in, are there any questions on what I've talked about, to this point? Because we're about to get in the weeds, which is fun.
Chris, I put one in the chat. When I know the employers, there's a lot here.
Yeah.
And there's no employer that I know of that is up to speed on all of this. And so, is there a guide available or maybe one that can be developed that employers can use to demand actions their consultant take to comply with all of these new requirements? There's so much here.
Yeah.
The benefits director, which is a one or two person shop, is never going to be able to get into the weeds on this as is, seems to be required.
So, short answer, no, there is no resource that I'm aware of. Other than uh, and I'm not like plugging anything, but the resource that you have and that I made available to you and your employer members, there are, so the last column, and there are four charts that I walk through. There's an audit and compliance chart that says what every audit and compliance provision of each, the DOL, anticipating that that will become final, and the CAA, like what does that mean from a contract perspective for you? So it's not a guide, but it's the closest thing I can point you to at this point from an employer resource perspective. I can say that, I'm hopeful that consultants out there, the big consultants that run RFPs are thinking about this proactively and not waiting until that last year when the 30 months kicks in, and that they're actually thinking about this now and putting these guardrails in their RFPs and in the contracts that result from them.
Got it.
But it's like drinking out of a water hose right now
Yeah.
in terms of
Yeah.
everything that's coming out. We
There's,
even we have lawsuits and FTC orders and rules upon rules and laws that and there's more to come, right? I do think there's more to come out of the legislature. So short answer, no, but
okay.
hopefully uh, we're just going to have to, stay very fluid, I think.
Yeah, so employers are just becoming familiar with it. And I couldn't help but think that chart that you showed with all the potential siphon points of dollars in the chain there and assessing reasonableness. And my thought is, well, what's reasonable in each of these buckets? No
Right.
idea. You know, it'll be interesting. So I guess this is really to familiarize with employers with what's out there and what's down the pike, and not to panic right now because they don't have all this, because they don't.
Right. No, but
Right.
just becoming familiar with these concepts will enable you to push your consultant um, to, I think, to push your consultant to be more, I don't know, demanding, strategic, forward thinking in terms of, what they're putting into the RFPs.
Yeah.
Again,
Yeah.
I think that just being able to speak the language sometimes and ask that question, right? So maybe you have your upcoming annual strategic meeting with your consultant, right? Around this time of year that happens. There's a very sort of regular cadence to these things. And so as you're having that meeting, maybe you put on the agenda, I want to understand what our plan is to comply with CAA of 2026 when these become effective. How does it fit into our procurement schedule, right? How does it fit into our strategy? And sort of push them to think about it. You don't have to become the expert in these things, but I do think it's good to be aware of them, um,
Yeah.
so that you
Makes,
can, yeah,
yeah. Makes total sense. I can see the next version of the field guide incorporating some of this, given that it's a evergreen document. So more to come.
yeah,
Appreciate it. Thanks, Chris.
yeah, of course. Okay, so I wanted to walk through a few examples, and I don't know that, did I do this? Can you go back to the last slide? Um, it looks like I missed one. Can you forward to next one? All right, let's start with, for some reason, I missed this very important first slide on example 1. So we're going to start with example 2. So example 2, we have a mail channel drug, generic, again, mail service pharmacy, PBM owned mail service pharmacy, and a 90-day supply. Pricing method is MAC. All right, next slide. That's sort of the, how to understand the big picture. Now, these are all fields that you are going to see in pharmacy claims data. So, I'm sort of walking you through what you're going to see. It just, in order to get all of those fields and explain it as, a file might look like, was a little too heavy, I think, for a slide. So I broke it down in a different way. So let's assume the price is 15 cents a pill, quantity of 90, right? The ingredient cost on that is going to be $13.50. And the ingredient paid is $13.68. Okay. Looking pretty good. Our dispensing fee is $1.25. So the pharmacy reimbursement components here are going to be the ingredient paid, dispensing fee. So for a total reimbursement of $14.93, right? That's what the pharmacy is receiving. The member on this drug has a $20 copay. Not a very generous plan. $20 copay on a generic for a 90-day fill. Now the total adjudicated cost, right? Ingredients plus fee is $14.93 on that drug. The member is paying the pharmacy $20, right? That means the plan is left paying $0. But the total collected by the pharmacy is $20. So where does the difference go, right? If it is a mail order pharmacy that is owned by the PBM, the difference of $5.07 is not going back to the employer. It's going to remain with the PBM enterprise or that PBM owned pharmacy. Now, oftentimes there are provisions or requirements that the member is going to never pay more than the cost at point of sale, but not always. So it's something to be aware of. Next slide. All right. This is a claim. Hold on one second. I'm going to see if I can find. All right. All right. So it's a medical drug. And I know that we're talking about PBMs and pharmacy, but I thought while we're at it, we might as well address a medical drug because they're very important as well. So this is sort of level set. It's Avastin. Billing code for a drug on the medical side is it's your HCPCS code, J code, site of care, your dose. Now the hospital acquisition cost is roughly $3,800. The hospital billed charge for this particular drug is going to be $8,000. And the negotiated allowed amount on this drug is $5,500. Next slide. Oh, that's where my slide went. I got them mixed up.
So you didn't lose it.
Yeah, I didn't lose it. Well, so we have a hospital, I just walked through that. So unlike a pharmacy claim here, you're not going to see the ingredient submitted versus the ingredient cost allowed. What you're going to see is the billed amount and what the ultimate allowed amount is. That's the only visible pricing step that you're going to see. So the provider margin here on this particular claim at that estimated acquisition cost is $1,700. That's the buy and bill margin. Again, there's no PBM spread layer here because the margin lives with the provider. Now, I haven't done an example with this, but one of the things I want to point out is you can imagine, let's imagine that this is a 340B hospital. Okay. The 340B hospital is only paying their ingredient cost for this particular drug, hypothetically, is $100. Could even be a penny. It might be one of the penny drugs. Substantially lower than 3,800. Let's say it's $100. If it's a 340B drug and the hospital is able to charge 8,000 and the allowed amount again is 5,500, you're paying a huge margin to the hospital for that 340B drug. Again, I think it's, one of the things you might want to do after you get off this call is go figure out where your highest spend hospitals are and then run a search to see if they're 340B. It might help you understand when you're in negotiations, or if the hospitals are crying poor, one of the things you might look at or see is that the hospitals are able to acquire a lot of these drugs if they are 340B at a very reduced cost, and yet they're charging you as if it wasn't reduced. The other point here is, okay, let's assume that on this particular drug, there was a medical pharmacy rebate. Not super common, but common enough. And you have a pass-through contract with your TPA. If that 340B, if your hospital now becomes a 340B hospital, you're not only sort of helping the hospital's margin, you're also losing dollars in that rebate because you're no longer eligible for a rebate if the hospital is buying it at a 340B price. That's not what we're necessarily here to talk about, but I do think it's important to understand the economic dynamic there. Okay, so we'll go back and walk through example 1. If you could go to slide 1. Okay, yes. I thought this would probably be a good example for the group. So Ozempic, we have our NDC code. Again, these are all fields that you're going to see on a header in pharmacy claims. Our channel is mail pharmacy, PBM owned. Quantity is 1. Your pricing is AWP. It has a dispenses written code, so no substitutions here. A supply is 84 days. It's interesting. The supply is a 12-week supply through mail. Now that's something you're going to want to remember. And status paid. Next slide. Sorry, yeah, go back to, okay. The first, yeah, that one. All right. Yeah. Okay, so your AWP reference, again, these are all headers, is 507.98. Your ingredient cost, right there, 403. Let's say that you are supposed to be paying 80% of AWP. That's what your contract says, or that's what your guarantees are, your discount. That tracks, right? You can check that math, because if you know what your AWP reference number is and you know what your ingredient allowed cost is, you can check the math on whether or not you're getting the right discount. And that's within the typical brand discount range. Okay, so now I'm going to look at my dispensing fee, $1.25. That aligns, that tracks with the lower mail dispensing fee, and your pharmacy reimbursement components. So the pharmacy ingredient costs the pharmacy is paid $406. That's their cost. Again, dispensing fee. Their total is $407. So now we have all that information from our file. And what we want to do is we want to look at the allowed, what the allowed column is. Okay, so it's allowed at 403, and the ingredient paid is 406. So that means the ingredient paid is slightly higher than the allowed, okay, by $2.70. Possible explanations, there are a few. It's not so significant, but it's something that you'd want to pay attention to across your claims. So it's small, but technically your paid amount exceeds your allowed amount reference number. If that $2.70 was $20.70, that is definitely something you'd want to know. And it's something that you can figure out from looking at this data. In this case, you have a member patient pay of $101.31. They have coinsurance in this case. So if you know your coinsurance plan design is 25% coinsurance, you can do the math. 25% of 403. That's very close to 101.31. So, that tracks. So now to check the totals. The plan paid 317. The member paid 101. So your total paid amount for that drug is 418.91 cents. So the adjudication math on this claim reconciles. Again, you're finding each of these fields in your claims data, and these are some of the things that you're looking for to check the math, so to speak, on your PBM spend. Next slide. So here's where I think we should pay a little more attention. So that math reconciled. Now, what was paid to the pharmacy? $407.93. The pharmacies paid $407.93, but the total paid between the plan and the member is $418.91. The difference is about $11. That's $11 in spread pricing. That's structural spread. So what does this particular claim demonstrate? It was adjudicated correctly. The contract math was applied correctly. The member cost share is logical, and the totals reconcile. There aren't any obvious red flags. But what we can see is there is retained margin from the spread. And if we know that the pharmacy is vertically integrated, we know where that money is going, right? The other thing we'd want to pay attention to here is the fill length. The fill length of 12 weeks, with a drug like Ozempic, I don't know, that could be standard. But what, you want to pay attention to, if you have a drug, let's say we know has a lot of bad side effects, or we know has a really high abandonment rate by members within the first 14 days, we're not going to want to have a 12-week fill on that drug, right? We might want to put some parameters in place that wouldn't trigger, an 84-unit claim, especially when it's that high cost. And then the dispenses written code, it forces brand. Now, with a drug like, some of, these weight loss drugs or GLP-1s, we only have brand, right? But where there are generics available, you're gonna want to know, by looking at that code, you can see if you are being forced into a brand drug transaction versus what could be possibly a generic drug transaction. That generic drug transaction might not only lower your plan cost, but it might also lower your PBM enterprise margin, But again, you're gonna want to know and figure that out from, and I'm not saying every employer is gonna go look at every dispense is written. I'm just saying like these are the things you want to pay attention to, or have your consultant pay attention to, or think about as you're crafting your RFPs, your contracts, and pushing your PBMs on these issues and asking smart questions, right? For a specific drug, is this dispense as written? What is our lost drug policy? Like, do we have a limit that they can only lose once per year and we're not covering after that? So again, these are some, they lead you to smarter questions, which will lead you to better outcomes. So I think we went through all the examples and left enough time for some questions. I hope that was helpful. I know it was dense, but I think that this is where we are. We're in the weeds, and we have to be.
Uh, Chris, there were a few questions. Apparently, the chat was disabled for some
Okay.
folks. And so I just noticed them in the questions. But the first one was, and this was at 12:32, so I'm not sure which slide we were looking at, but are the data files readily available, or are these files we have to push for when we contract?
You're going to have to push for them, especially at the level of specificity that I'm talking about. That being said, this data, um, much of it will be available given some of the recent enactments. Now, some of the information that's going to be available to you, made available to you, is going to come in the form of more aggregated reporting. But in the end, that reporting is pulled from, the pharmacy claims data, the raw data. Um, so when that reporting is being formulated and when you're getting that reporting, again, you know where to ask questions and how to ask questions and what the components of what's being presented to you, right? You know how those components came to be. But I would push for having this data, and hopefully
Let me
we will
let
have.
me ask you this to know which to push for. In the field guide, we provide these are the
Yeah.
specific fields you need on the health plan side, and then you also provided them on the PBM side. If they request this data, will they have the data they need to make this all happen?
Yes.
Perfect, perfect. So again, that's available in the field guide, downloadable through the website. But again, employers only, and we do screen that. We have someone who checks. In fact, if you give us a Gmail address, it will be rejected automatically. We have folks that anyway. That I'll just leave that there.
And I
Um,
would say, Chris, too, if you're able, again, I know that there's this feeling of like, if I got this file, like, I don't know what I'd do with it. How would I, right?
yeah.
There are open source coding that you can find, open source codes that will allow you to query the data, right? So you can find codes that you could put into Excel to filter for finding spread, right? There's a lot of information that's sort of out there. As some of it's AI driven, but querying this data is seems like an insurmountable task for an employer of 500 people or 100 people, but it is very doable, especially using some of these open source excuse me, open source resources.
Another question then, some PBMs, and I know this happens for fact, some PBMs will not provide the allowed amount saying it's proprietary.
Sorry,
You're almost there, Chris.
I
You almost
know.
made it.
Yeah, I mean, I think that that's unfortunately that's where we are today, and that's the line being taken. But as we move into the new world, which is here, right? And prepare for the new world, meaning for 30 months from now. Um, I think it's going to be much easier, not easy, but easier to point to a law that you're going to need to be compliant with and say, I want to contract with a vendor that is going to allow me to assess these things, right? And to engage in these processes that I very clearly have to
Yeah.
do with information I have to have,
Yeah.
um, in the future. So I think you have a
I
much stronger case.
I get it. I know in the guide, it's on the health plan side. I don't remember from the PBM where you send this letter and they're going to come back and say this, and then you got to come back and say that. I assume those same principles would apply here on the PBM side.
Yes.
Perhaps, yeah. So that's in the guide as well. And here's another good question, because you mentioned a medical plan example. How would we see the estimated hospital acquisition costs on J-code drugs?
Yeah, you won't know. Um, unfortunately. Not the acquisition cost. You'll see what you're getting charged. But I think that there are there are indexes and there are other, there's way to find prices of drugs. Not hospital specific, but you can get
Yeah,
an idea, right? And you can also know what a 340B price might be.
yeah.
And if the delta on or what Medicare is paying, right?
Okay.
Um, so yeah, unfortunately, the answer isn't a good one right now.
Mm.
But let's push for it.
It's a lot here, and maybe just give us the 30-second because we're about ready to close, but a little preview of what we can expect on March 26th.
Yeah, so I think the plan has been to what data do we need to look at? How do we get it? What does some of it mean? What is the terminology? But ultimately, what is the strategy that this data is going to drive? How do we then take all of this information and use it not as a one size fits all, but to create smart plan designs and strategy that fit the data that my members, that I'm seeing in my members, right? And be strategic about using this.
Um,
Uh,
just to
Very good.
chime in, yeah, Chris, I just want to ask you, I noticed one of the questions was, it's so comprehensive and there's so much information that you've just provided us, which is wonderful. Uh, doing something about it is going to be the biggest challenge for benefits managers. So I can see how they would be so interested, most benefits departments, in hiring a benefits analyst to do some of this work. Because like they said, the consultant won't do it, the health plan won't do it. And yet it would be so powerful to have access to that data. So I think
Yes,
there are
an
benefits
analyst
analysts in that
is,
crowd. They need to sign
and
up.
and I would, if an employer is on the fence about it, or they need to make a case to their CFO or their leadership,
Yeah.
if you can find, and if you need an example, just write me. But if you can find in your own claims, just one sometimes, right? Like one overbilling mistake or one duplicate claim, something, you can pay for your salary 4 times over for one analyst. It doesn't take a lot for this position to pay for itself multiple times over in a plan year.
I've heard that so many times, but again, convincing the CFO here.
If they
There's a
if they need
comment.
some compelling examples, I have some slides that any CFO will look at, and their head will explode, and they'll say, "Who are we hiring to fix this?"
That is great. Here's a great comment maybe to close on. This is a great presentation. Thank you so much. As coalition members, we are better equipped to take next steps and capitalize. It is wholly unrealistic to think our consultants will help us with this. My consultant does not have the will or expertise to advocate on my behalf. Today, they receive all of my medical and RX data and are unable to share the data with me. I believe that the open source resources are available and will need much more support to take the next step. So, beginning, not the end.
Great
Yeah.
closing comment. So Chris, thank you so much. I just want to remind everyone that the third part of this field guide series is on March 26th. It's a Thursday. Please mark your calendars. We'll obviously send you reminders about this. And Chris will take us through another hour of the most amazing, helpful information. This is just way beyond what you get ordinarily in any webinar. So Chris, thank you for doing this.
Sure.
Mark your calendars. We shall be back in touch with you, and consider joining the Texas Business Group on Health, and as part of it, the Texas for Employers for Affordable Healthcare, where you can get this field guide for yourself. So
Yeah,
we'll
it's really good.
send you
So,
info on that as well.
and Chris, best wishes to you. I hope your voice gets better over the next few
Yeah,
days.
okay. You did very
I,
well.
I
Yeah.
feel better than I sound.
Yeah. And by the way, it's dark there because Chris is in England. That's why the background there is dark.
Oh
So
my
she's actually
goodness.
putting up a late night as well. So thank you again so much.
Well, double thank
Bye,
you then. Okay.
bye,
Thanks.
folks.
Bye now.
Bye.
Thank you again.